welcome back. I am going to discuss with you all the chapter that is chapter 8 in your Jarvis health assessment book. I thought it would be a great idea, since we're starting health assessment together, that we review some of the assessment techniques that you're going to be using before we get into any major systems. So that is what we're doing now. It's called assessment techniques and in the clinical setting. This basically, you've got this PowerPoint, and basically it just talks about how important it is to know that health assessment really is, if we're doing a physical exam and health assessment, it involves collecting health history data as well as doing a physical exam. So keep those two things in mind. So the history is extremely important. And what you'll see and what you've been reading about, especially in chapter 4, it talks about that health history gathering and how important it is to do using all your communication skills that you've learned, the therapeutic communication skills when you're interviewing your client and gathering health history data from them. So what we consider as subjective data in nursing is that what the patient tells us is going on, or why they've come into the hospital or our clinics. And that's subjective data, what the client tells us. And then the objective data is what we actually examine or see, or maybe even some objective data could be some lab results, vital signs, that type of thing. So in order to do, so we've already talked about, or you've read about, the health history, which is the subjective piece. So putting it all together creates kind of a database, and you've done some care planning already too, where you've had to gather subjective data and then do your physical exam. So the focus that I wanted to talk with you about would be the physical exam techniques you're going to use for every system while you're in our health assessment class. And we know that it involves these technical skills. Sometimes the technical skills are just knowing where to put your hand, or what part of your hand to use, or maybe using a stethoscope or other tools. And also then you can relate these skills back to your patient care experiences. But the basic thing you're using with health assessment are your senses. So you as the examiner are going to use your eyes, your smell, your touch, and your hearing to gather this data during a physical exam. And they have to be done one at a time. So no matter what system you are examining, what is the first thing we do? What is the first step or tool that we use? And that is inspection. And there was a theorist that said once that inspection is called concentrated watching. And I've had many doctors, I'm a nurse practitioner myself, but I've had many doctors say, and nurse practitioners say, that inspection is the greatest thing we as healthcare providers can bring to our patients. Concentrated watching can tell us more than what we touch, what we hear. So remember, that is your greatest asset, is your ability to inspect. So that's the first slide after this, cultivating your senses. Close, careful scrutiny, first as the person as a whole. And there is a chapter that you've read on general survey. And general survey, from the time you walk into your patient's room, you are ready to see what is going on with that patient. You can tell a lot about their mental attitude. You can tell a lot about how they're dressed. You can look at their skin color. You can look at their posture. All of those things are part of the general survey that you've read about. And that is part of the careful scrutiny. You can tell immediately if that person is relaxed and breathing okay, or if they're in distress. And based on what you determine will determine what intervention you're going to do next. So that is the general survey. And as you proceed through each area of examination, you'll continue inspecting the skin, the color of the skin, the person's demeanor, and that type of thing. But remember, inspection does come first. Now, what do I need for inspection? Well, I need a good light. And so sometimes the fluorescent light's okay, but sometimes you need an extra light. So it's not a bad idea to have your pen light or an otoscope light, something that you can magnify and look really carefully, maybe at the skin color or at the skin, to see if there's any lesions or bumps that we'll talk about. You also need to make sure, if you're doing inspection, that the part you're trying to inspect is accessible to you. So it's better to access the skin directly or the body part directly, and of course keep the person integrity and respectfully covered, but those are some things too. And like it says here on your PowerPoint, it might be an otoscope or an ophthalmoscope that you would use. It could be the pen light, or perhaps you'll need other kinds of special specula that would help you enlarge your view. At my clinic, I use a otoscope that is magnified, so I can really see the eardrum, and it becomes magnified, and it really helps for visualization. After you've inspected, the next thing you're going to do is palpate. Now, palpate means hands-on, and it's a sense of touch. Now, there's different parts of your hands that are more sensitive. The backs of your hands, which are called the dorsum of your hand, is really sensitive to touch. So after, and this kind of goes into our skin, hair, and nails talk together, but the back of your hands can feel temperature. So if you're trying to feel whether or not a person is hot or cold, use the back of your hands. If you're trying to see if you've got a swollen joint that might be hot, use the back of your hands for temperature. The other parts of your hand can also be used to see about smoothness, texture, whether or not the person's sweating or not, the moisture. We also use palpation to identify any kind of pulsations, maybe a heart exam. We could also use our hands to assess abdominal area, the abdominal region, to see, do we feel any organs or masses, that type of thing. The word crepitation, where do we feel that? Well, usually in a joint. Sometimes, like for instance with the TMJ, you might be able to feel a little bit of popping or crepitation, or it could be in the knees or in any of the joints. So also through our touch, we can identify if a patient has an area of pain. And so obviously you don't want to palpate that painful area first, no matter where it is, because that might stop the patient from being cooperative with you. So palpation's important. First was inspection, then was palpation. So this slide just tells you what I said, is what part of the hand would be best suited for each of these. Fingertips might be for texture and swelling and pulsation. Fingers and thumb, you could put them around things, so maybe the position or shape of an organ or mass. So sometimes we use our fingers and to identify how big a vessel would be, our fingers and thumb, or maybe to be able to see the edges of an organ. So the dorsa or dorsum of the hands and fingers, because of temperature. And then sometimes we use the back side of our hand, which is called the ulnar side. If you think baby finger side is the ulnar bone, and then the radius is on the thumb side. But this side of the hand, sometimes we put on the chest wall when we're trying to determine, are there vibrations in the chest, which is called tactile. It's vibrations, which is it is very normal to feel some vibrations in the chest when the person talks. It's called fremitus. I couldn't remember the word for a minute, but it's called fremitus. All right, so palpation. Also, some other things about palpation is we usually start with light palpation, and I'm especially thinking about in the belly, but there are some times I'm giving you the 4 techniques: inspection, palpation, percussion, and auscultation. But there are some systems that you absolutely do in different orders. So even though we do light palpation for surface area things, sometimes we have to go deeper for deeper organs or masses that might be available. This just reminds you that you want to avoid the painful parts so that the person's cooperative with you. And sometimes you need bimanual palpation, and that might be because there are organs that are larger. For instance, if a woman has a large breast, they might use bimanual for breast exam, or if I'm going to try to feel a kidney or something else, you might need two hands coming together to do that. So remember, again, inspection is always first. Palpation is part of the tools, but it's not necessarily the second thing you do, particularly if you're in the abdomen. I'll just tell you that. You always do palpation last in the abdomen, but you can do it second in the chest wall or on joints and that type of thing. The next tool that sometimes is used is called percussion. And as RNs, we don't use percussion that much, but as advanced RNs like myself, as an NP, sometimes I do use percussion. But certainly, percussion means a tapping that you tap on the client and you hear a noise. And it talks about short, sharp strokes. But with percussion, you can hear whether or not there is normal tissue underneath the body surface area, or maybe you've come upon an organ or a mass of some kind. So usually the places that we percuss would be the lungs in between the rib cages. We percuss lungs, and the normal note that we hear with healthy lung tissue is the term called resonance. And then the other place that we can percuss is the belly. And the belly's normal note in adults is called tympany, like a drum. And the tympany is caused from air in the bowel that would cause that sound of a drum. Now, there's a couple ways if you have a couple ways to do percussion. One is called direct and one is called indirect. So direct percussion means that you're tapping directly on a skin surface or directly on a chest wall surface. And sometimes we do that in the back. If we have a person's back turned, we sometimes directly percuss on the back costal vertebral angle to check for kidney pain. So directly on the person's back or skin is called direct percussion. Another way that we percuss is called indirect, and that is where you put your own hand surface down, usually a middle or first finger, and then you tap directly on the surface of the person. So if you put your hand down and then you tap directly on the person, and that is called indirect, and it basically will give you different sounds. If you're in between the lungs or the rib cages and it's lungs, it'll sound kind of like a higher pitched resonance sound. If you're in a bowel area, then it sounds most likely like tympany. So to be able to tell, this is called indirect. You could puff your cheeks up and then tap on your cheeks, and that sound is a sound of a hollow sound that's called tympany, and that's what you would find mostly in your belly. So percussion can be useful. It can also be useful because you can see where the bottom of the liver is and maybe a spleen. So if you have liver or spleen enlargement, those also can be told by percussion. This shows you a picture of indirect percussion that I was trying to show you with my book, and it didn't work out very well. So the last assessment technique is called auscultation, and you all are familiar with it because you've had to do assessments already in your clinical. So auscultation is listening, and what do we listen to? We listen to lungs, we listen to heart, we listen to bowels. Those are the three things mostly that we listen, and we also have different sounds that are heard in the stethoscope. You all know that the stethoscope normally has a diaphragm size, which is the larger size, and also a bell size, which is the more narrow size. So getting a good stethoscope with kind of a short tube can really help you when you're auscultating, as well as getting used to the sounds. Of course, this is a stethoscope, and I don't have to tell you about that because you've used it. So usually with the bell of the stethoscope, that is the one that is the best for hearing sounds like murmurs in the heart, for murmurs. Here's some other equipment that we use for health assessment that you might use in your assessment toolkit. A scale, certainly, for weight, and also something for height. Sometimes folks would like a skin fold test, and they will try to determine the amount of fat someone has. We don't use that very often. You all know a sphygmomanometer is a blood pressure cuff. A thermometer, of course. Pulse oximetry, we've you've used before, but it's a sensor that talks about the oxygenation level in your patient. And of course, we're always looking that it's 90% or better. You have pen lights. Looks like they've repeated a couple things here. A tuning fork. Tuning forks can be useful for hearing tests, even though that they say that whisper test or audiometry is just as helpful. And then some others that you might see as well here for your health assessment exam. You might need a pocket vision screener if you don't have a Snellen chart. A pocket vision screener can be used, but a Snellen chart is also useful for visual acuity. And you can see a few others. It's nice to have a tape measure so that you can measure calves to make sure there's no swelling in one. What else do we measure? We measure lesions, the size of lesions, and it's nice to have a centimeter and a millimeter ruler for that. I like having a reflex hammer because doing deep tendon reflexes are always useful. A split tongue blade, that sharp object, it can test either dull or sharp when you're doing your neurological assessment. If you're doing any kind of female or male genitalia exam, you might need special equipment or speculums. Of course, we need gloves because with gloves, if you identify that a person has a lesion, then you should put your gloves on before you do your exam as well. Prior to doing anything, you've met your patient, you've already done the health history that we've talked about in your chapter 4. Now it's time to do the exam. Wash your hands. And I know that's been emphasized to you all through nursing school, but hand washing is a simple, effective way from preventing cross-contamination. And even on our equipment, we can get contamination on equipment. So wash your hands. And one of the reasons I think we have MRSA in our hospital settings, which is you all know methicillin-resistant Staphylococcus aureus, is because people are not consistently washing their hands when they go room to room or patient to patient. So do it in front of the patient. Make them feel like this person really cares about me, and do it right in front of them. Before and after physical contact, or after removing gloves. Gloves are not protectors. You can't reuse gloves. You all know that. And of course, all the OSHA principles you've already had testing for. At Walters State, you took another test for ETSU, but any contact with blood or body fluids, secretions or excretions, would be a need to wash your hands, and certainly use gloves beforehand. And maybe use other PPE equipment, personal protective equipment, to make sure you don't get an eye splash, or if you need a gown or something, depending on what the person has. So please wear your gloves. When the potential exists for contact with any body fluids, wear your gloves. Remember that they are not reusable. You have to wash your hands before you put them on and after you take them off. And what else do I need? Ask yourself that. What other protective equipment do I need? So now we're getting ready for the general approach, and this is not a most comfortable thing to be examined by somebody else, because it requires a little bit of intimacy, and it requires you coming into someone else's personal space, and it requires a person to be undressed, and those are not comfortable things. So you have to be very professional and calm and very comfortable with yourself and your skills. This is not the time to be nervous and say, I'm a nervous wreck because this is my first time ever doing an exam on a patient. That is not what you want to do. You want to come in with confidence. You want to be unhurried. You want to use a good, gentle voice. You want to make them feel respect and treat them with a great deal of dignity. So this slide just reminds you how anxious the patient might be. And if you can have all your equipment so you don't have to go in and out of the room, everything gathered, and make that person feel very comfortable with your demeanor, then it'll go a long way. So what you want to do is, of course, introduce yourself and let them know what you're going to do. Hi, I'm Carolyn Merriman. I'm going to be doing an exam today, and I need to do, this is what I would be saying if I were doing the head to toe, I'm going to be doing a exam of your heart and your lungs and your skin and your eyes and ears and nose. And do you have any questions before we start? And then ask them, you know, what their name is. Tell me your name. And then, of course, you'll be doing some mental status exam as well. But how you want to approach this hands-on is to maybe do something that's considered safe and non-invasive. And everybody's kind of used to a blood pressure. So that's not a bad idea to start with a height and weight and go ahead and get the blood pressure and pulse and respirations. Now, if I am trying to make a person feel comfortable, I'm not going to say lay down and let me listen to your heart first, unless it's an emergency. I'm going to start, they're going to be sitting up, kind of comfortable. I'm going to have a drape over their lap, and I'm going to say, would you please show me your hands? And so start with the hands, because people, after you've done the blood pressure, they've gotten kind of comfortable to that touch, but you can start with the skin and the assessment of the hands. Have them hold their hands out, and then you can proceed from there. You can look at the hands, you can pull the gown up to the arms. This is getting into our skin a little bit assessment. After you've done that, maybe it'll be time to do, if you're doing this skin first, then go down and look at their legs and maybe their toes. That is not very invasive. And then I would probably concentrating one step at a time and making sure I don't forget anything after I've gone like skin. Then I'm going to start at the top. If it's a cooperative adult that has had this before, you know, with an elderly person that might need, you know, some variations because of confusion or not, or a smaller person, a child, you can change your exam. But for an adult that is used to this, go head to toe. After you've started with vital signs and the hands, then start head to toe. And that's where you're going to be looking at the person's hair and eyes and doing your eye exams. Maybe having them open their mouth and check their ears, doing some lymph node assessment. Of course, always looking at symmetry. Symmetry is a huge word in health assessment. Is everything I'm inspecting symmetrical? And then go down and do your lymph node assessment. At this point, if you've done all that, then maybe it's time to do a lung assessment, looking, inspecting, and then listening to your lung sounds while they're sitting up. You can do it on skin, but keep them covered. You know, so don't go over close. That's another thing when you're auscultating, is you don't go over close. And then you can have them lay down for the heart and for the abdomen, and then do some musculoskeletal things, but be head to toe and do as best you can, because for an elderly person, they don't need to be hopping up and down and up and down. So try to pull it all together so that you are not making that person uncomfortable. While you're doing the exam, you might have some brief health teaching going on, or if you find something you want to ask them about, but that's not the purpose at this point when you're doing your exam. You certainly want to describe what you're doing before you do it, before you start positioning the person and getting their feedback, and then summarize the findings for your person. You can think back about getting an exam yourself and how irritating it is to have someone that's cold and it won't interact with you versus someone that's warm and seems to care about you and is also professional and makes you feel comfortable. And certainly, you know, those are some of the things. And then if you have to get more intimate with your genitalia or your breast exam, they will trust you at that point because you've made them feel comfortable. But you still can do those areas as well in a very professional manner. This is just talking about the setting and the environment. Now just think again about being in an exam room, and think about what the worst situation has been that you've ever had. I'm trying to think of a situation where I was freezing, they left me in there for 30 minutes in a gown. Those are not the way that we want to treat people. So, is it possible? Certainly, let's do all the history before we get people undressed. We don't want to ask them personal questions when they're vulnerable. But once you get them to a point where they are undressed or in a gown, then it is, or in a hospital bed, it is time to really focus and get this exam done in a fashion that will make them comfortable, as well as not procrastinate or prolong it as well, because it is not the most pleasant thing to be in this kind of environment or setting, as you can tell. This is just talking about some developmental competence, and for our health assessment purposes, you do not have to do children or all the way through adolescence. We do talk about the aging adult, however, or a sick person. And an aging adult, just remember that you don't want to position them several times in this exam, so try to minimize the amount of time they have to go up and down. Sometimes they have blood pressure issues, so you all have heard about hypotension, postural hypotension, how important it is to raise a person from different positions slowly so that their blood pressure doesn't drop. And then if a person is ill, we may not be doing a total head to toe. If I have someone that comes in with a sore throat, I may do a focused exam just on their eyes, on their mouth, their ears, their sinuses, and certainly heart and lungs for every patient. So sometimes we do complete physical exams, and sometimes we do focused physical exams. This is giving you a little bit more about the ill person. If they're in distress, you might want to alter that position. For instance, if they're short of breath, they may want to sit forward in a tripod position, and you all have talked or seen that. If someone's got ear pain, they may need to also sit up. And then if they're just too tired to sit up, you might have to lie them down. So you all be the guide. You've got that intuition already as nursing students, and you be the guide. What do I need to do for this sick person? How can I change my examination technique to help them the best? If you need to do an emergency, like maybe you're the nurse in an emergency room and someone comes in and they're very sick, the question would be, what should I do? If someone's coming in an emergency, what should I do? And so basically you would do life-saving measures for that person, maybe getting a few focused history questions like, do we know any allergies going on? But you don't need a complete history and physical at that point. You need to do life-saving measures and maybe some focused, are you allergic to medicines or anything else that will help you care for that person immediately? And the other things can wait. So this is an introduction to approach and the 4 techniques that you're going to be using, which are inspection, palpation, percussion, and auscultation, and then giving you some thoughts about how to make the environment the best for your patient, and also how to prepare your patient for the exam, and how we can use our senses and cultivate our senses to be the very best healthcare providers while we're doing an assessment. Thank you very much.